Hello, everyone, dear friends, dear colleagues. Unfortunately, I will not be able to join your great conference in person. So I'm sending this lecture, and I hope someday soon we meet in person. Uh, my talk would be about how to shorten the duration of the treatment of bone infection. As you already know, I'm one of my positions is I'm the chairman of the fellowship committee in the CCOT, and I would encourage you, especially young surgeons, to apply for fellowships to attend a training program outside of your country for exchange of information, for gaining knowledge, for gaining experience, not only in medicine, but in life too. So I would encourage you guys to join CCOT, the International Association of Orthopedic Surgeons, and to apply for the fellowship programs we offer, either the regular fellowship or the virtual hybrid fellowship. Greetings from my country, Egypt, the old civilization, the great country, the people who went through so many hard times and so many great times with great achievements. We have so many layers. We withstood the test of time exactly the same like your countries, like most of Eastern Europe and Northern and Central Asia. So why bone infection is a problem? Unfortunately, soft tissue infection, they have good blood supply. And when you give antibiotic and minor debridement or drainage of pus, usually that help. Or if the patient doesn't get cured, as in general surgery, they die. But unfortunately, in bone infection, it's chronic. There's no cure, no death, miserable life, and long duration of suffering for the patient and for the doctor. Because the blood supply of the bone is very different from the blood supply of the soft tissue. So you get a patient with chronic infection, usually with a lot of mental exhaustion and psychologically and physically. On the other hand, the doctor is worried about how to promise the patient, what to say to the patient when we expect the cure for for this disease. So you get so many problems with these patients, and we get referral of bone infection cases from all over the world and from all over the Middle East and from all over of Africa. As you know, around Egypt, there are so many wars and so many conflicts going on right now. So we get these patients with so many surgeries before they present to our limb reconstruction center. And many of these patients, they have multiple sciences, osteomyelitis, soft tissue loss, osteoporosis due to disuse, the joint stiffness, the complex deformity, the limb length inequality, the resistant bacteria. So there are so many problems that cannot be solved just by saying we have this modern technology that will help you. In my population, limb internal lengthening devices like FitBone or precise nail cannot be used in cases of infection because there's infection, because the bone size, because many of these cases are children with epiphysis, because of the limited ability of these internal lengthening devices to give long distance bone lengthening. Because as you know, most of the research proved that these devices are safe for lengthening up to 4 centimeters. After that, there is risk of mechanical failure or jamming or many other problems, mechanical problems. Also, it is expensive, and many of the patients that come to our country or even from my country are not rich. They cannot afford such technique. On the other hand, external fixation with software like spatial frame or other frames, uh, these frames, it's nice. It's easy for me. It make my planning easier, my instructions to the patient a little bit easier. But still, the patient dislike the external fixation in general. He doesn't like this big thing that applied to his or her limb. And even with these perfect calculations on the software, when you apply it in real life, you get residual deformity because of the deformation and pin loosening. So even these calculations, which they expect that there is no modulus of elasticity or everything is going perfect with no soft tissue resistance or bone resistance for the correction. At the end of correction, you find there is still residual deformity. So it is not the perfect device for me nor for the patient. So this is a problem with the software kind of external fixation stuff. Still, there is a myth about infection. We need to think that we don't know everything about infection. Like, as you know, before, at the end of 19th century or the middle of 19th century, people thought that what's called miasma theory. They thought that bad smell bring infection. So if you avoid bad smell, you will avoid infection. Why they thought that? Because they thought when you go to the swamps or bad odor areas, the risk of infection is higher because it's not clean. Now we know because there is a lot of bacteria there, but at this time they didn't have microscope. So today we have the theory, the microbial infection theory, which says that there is high load of bacteria and low immunity. So this high load of bacteria with low immunity create infection. That's what we think. This is the classic theory for infection. So it is either patient problem that there is low immunity or doctor problem that he didn't sterilize the surgical theater properly, or there is an open wound that brought the bacteria inside the leg. But this theory explains only 2% of cases, which is the 2% of cases that get infection. So if you have the same surgeon in the same surgical theater on the same day with the same equipment doing total hips in 10 cases, you get one infection and get 9 cases with no infection. So why, though he used the same technique, the same everything, this patient got infected while the other one did not? So the assumption that a lot of bacteria and low immunity is the cause of infection alone is not enough to explain so many cases. Some cases did not get infection, and other cases got infection. Why? Unfortunately, we don't know. On the other hand, there are so many papers that prove that there is bacteria in our body, in our normal body, without any problem. Like, for example, this paper aspirated closed callus from fracture and sent it for culture and found 42% of these cases in the study had bacteria in this closed fracture hematoma. Another study aspirated hematoma from fracture neck femur and sent it for culture sensitivity. They found bacteria in 31% of the cases. Synovial fluid aspiration without any symptoms or signs of infection, just aspiration, 10% came with positive culture. Rheumatoid knees contained bacteria in 25% of cases. 50% of degenerative discs that was removed showed positive bacteria culture. Another study, intervertebral discs contained bacteria in 45% of cases of discectomy. On the other hand, when we talk about sterilization, this study is showing that they got this, they finished the surgery, clean surgery, ultra clean surgery, no infection. So they got the instruments and did culture and sensitivity for these instruments. After finishing surgery, they found 47% of instruments were contaminated. And these patients didn't get infection. So clean surgery, no infection post-operative. Still, when they did the culture and sensitivity of the sterilized instruments, they found 47% containing bacteria. So what I'm saying is just presence of bacteria per se is not the only cause for infection. There must be something else. Another thing we need to remember that we in the medical field, we only know 400 types of bacteria, only 400 types. So how many types of bacteria on the earth, on our planet? 2.8 million types of bacteria. So we only know 400 types out of 2.8 million types of bacteria. So when we talk about contamination, contamination per se is not really the problem. There is something else. Another thing we need to understand, as we were saying, the blood supply in the bone is much less than soft tissue. And when bacteria get to the surface of the bone, they get attached and create adhesion. And then some bacteria die and create a wall, a hydrophobic wall made of polysaccharides. And this wall create a castle for protection for other bacteria, so the immune system cannot reach this bacteria. So it get mature and then it send bacteria. That's what's called biofilm. And this is a problem. This biofilm get created in 15 days. So if you clean the bacteria before 15 days, they didn't get enough chance to create this castle or this wall to protect the bacteria from the immune system or the antibiotics. After 15 days, you already have the biofilm attached to the plate, attached to the artificial joint, attached to the surface of the bone. One of the things that we need to remember that this biofilm is hydrophobic, while culture is hydrophilic. Culture and sensitivity that has a high metabolic rate, while biofilm is a low metabolic rate kind of bacteria. So you may miss many kinds of bacteria and culture and sensitivity. So we still need to learn a lot about not only the presence of bacteria in cases of infection, we need to understand why the behavior of bacteria change and infection develop. It's not only the presence of the bacteria, it is not only the low immunity, there are some other factors that we need to understand before we really claim that we understand what is infection. Another thing I would like you to remember that when you treat infection, you need not only to think about mechanics, but you need to think about biology. We medical doctors think a lot about mechanics, about fixation, about how strong our fixation is. But you need to think about stable fixation and proper alignment, which is also mechanics, but also you need to improve the biology locally and systemically. Improving the general condition of the patient is very important. And unfortunately, many orthopedic surgeons miss this point. So you have to remember that if the patient is suffering from anemia, from diabetes, smoker, alcoholic, liver disease, whatever, you need to think about these details and improve it to get rid of the infection. That's biology. Another thing, the local biology at the fracture site or at the infection. You need to improve the blood supply. If there is some problem with the blood supply, improve the blood supply. In many cases, as I will show you, we do debridement and proper alignment and proper fixation and do muscle flap. Muscle flap is a very helpful tool for us to bring new blood supply to the area to improve the resistance. So you need to think mechanics and biology to help your patient. Biology is by improving the general or the systemic condition, and locally by bringing more blood supply to the area. Mechanical by stable fixation and by correction of the deformity. This is plus eradication or of infection focus where the biofilm is there by proper irrigation and debridement. So I will show you just a quick example. This patient with infected non-union proximal tibia, she is 40 years old. This is the sinus. We do the surgery with no tourniquet. I open the incision. As I was saying, the plan is debridement and doing muscle flap to improve the blood supply, and then we applied external fixation after that to treat the non-union. So debridement, improving the biology. Here, as you see, we do a CT scan before surgery to know where the sequestrum is. And as you see, we know where exactly the sequestrum is. I am not removing any extra bone. I know what I need to remove, and I just play with it, manipulate it, and it come very easily, as you see. This patient had two sequestra. This is the other one. And as you see, it's yellow with no blood supply. Here, the manipulation, and here it is. It comes very easy, just like that. So now we finished the debridement. The second step is we will do the muscle flap. We will take the medial head of gastrocnemius and bring it to the area to improve the blood supply. I will make it quick. So here we put local antibiotic. We freed the medial head of the gastrocnemius. And here it is. I'm bringing the medial head of the gastrocnemius. So now I brought the blood supply, and then we apply the external fixation. So what is the strategy for post-traumatic bone infection? We need CRP and ESR because still they are not specific, but they are very sensitive and very easy to do anywhere in the world. And it's very important to think about ESR and CRP as methods for follow-up. They are not sensitive, they are not specific, but they are sensitive. Alpha defensine and other techniques are good, but we up till now we rely on ESR and CRP for follow-up about indication of infection. Then also we do a CT scan to find out where exactly the sequestrum, because remember, we are three-dimensional creatures, not X-ray two-dimensional. So to find out where this sequestrum is, you need a CT scan. Another example, as you see, here's where the sequestrum is. So we find out exactly where it is by the CT scan. So that will help us to remove exactly the sequestrum without removing excessive bone for no reason. We do culture, and the culture we do it intraoperatively. We take 3 tissue cultures, not swabs, and the tissue cultures, we take 3 to make sure that we really got the right results. Mechanical, as I was saying, we need to reconstruct after debridement and bring new tissues. For the tissues, you need to convert open fracture or open wound to a closed wound, either by secondary healing, primary closure, delayed primary closure, split thickness skin graft if there is good muscle bed, full thickness skin graft if there is good muscle bed, random flap, local flap, free muscle flap. So we need to convert an open contaminated wound to a closed clean wound, even if there is a fracture. I mean, if you convert an open fracture to a closed fracture, you did a great favor for your patient because now you can put internal fixation. So if in the first 2 weeks within open fracture, you did multiple debridement and cleaned everything, and then you do a muscle flap or whatever to convert this open fracture to a closed fracture, you did a great job for your patient. So you convert infected non-union to aseptic non-union or infected open fracture to a closed fracture. So soft tissue coverage for us is very important, and we have a great team in our center that we cooperate with to convert infected open wounds and infected open fractures to closed fractures. Then we have the bone defect. The bone defect, it depends on the size of the bone. If it is now a clean defect, you can do autogenous bone graft, you can put allograft, you can use demineralized bone matrix, you can use bone morphogenic proteins, you can use the induced membrane technique, the muscular technique. Unfortunately, this is not a very predictable technique, but it is useful sometimes if the patient refuses external fixation. You can use distraction osteogenesis by Elizarov technique. You can do acute shortening. You can do vascularized fibrillar graft. Also, you can use amputation sometimes if there is something desperate. But in my population, in Africa and the Middle East, amputation is not like the preferred choice. This is an example of muscular technique. You do debridement, proper debridement. You put a spacer with antibiotic and intramedullary nail. After 6 weeks, you remove the cement spacer and put a bone graft in the induced membrane, and now it healed. And as many of you know, I have so many international publications about treating bone infection and these things. So you have to remember that radical debridement is very important. Stabilization, reconstruction of the defect, improve the general immunity. Presence of bacteria is not the problem. The problem is the behavior of this bacteria. Antibiotic is not a magic solution. There is no such thing called 100% sterile. For long distance defect, like this patient with chronic osteomyelitis destroyed most of his femur, we can do segment transfer over nail because we did radical debridement. So even if I put this thin nail, I'm not worried about the recurrence of infection. Another technique we use, for example, this patient had chronic non-union and infection distal tibia. As you see here, non-united and infection. Here, all this area is sequestrated. So we did radical debridement and we did corticotomy proximally and applied Elizarov external fixation to do segment transfer to move this segment distally till it reach the distal docking site. Now we finished the segment transfer within 2 months. So we do ESR and CRP. Our ESR and CRP is normal. And when I'm saying it is normal, I mean ESR less than 30 and CRP less than 6. Why I use these figures? Because these are the same figures that our colleagues in arthroplasty are using for revision. So they don't go back for second stage revision and put another total hip after infected total hip, except if the ESR less than 30 and CRP less than 6. That's why we use this figure. And now we remove the external fixation, put an intramedullary nail. So instead of keeping the external fixation for 9 months, we just used external fixation for 2 months and replaced it by internal fixation. And that helped. And we published this already several years ago. Actually, and also we did this study and showed that the use of external fixation followed by nailing give the patient shorter duration for rehabilitation, less general cost despite doing 2 surgeries. Another technique we use is time is very important for our patients. You can cure infection in 2 years and you can do the same outcome within 6 months. For patients, if you can shorten the duration of treatment, you did a great job for your patient. So for example, here we do 2-stage debridement in 10 days. What we do debridement, and then we put Heckman catheter inside the medulla, where we inject the antibiotic for 10 days, and then we take the catheter and go for the second stage. And this is also described in many techniques like this, like here, we put Heckman catheter for acute infection in cases of total hip, also in intra-articular infections, intra-articular antibiotics, in septic hips in children. So we put the Heckman catheter where we inject the antibiotics directly into the joint or directly where the infection is. So instead of injecting the whole patient and waiting for this antibiotic to reach the focus of infection in the joint or in the bone, we start by injecting the antibiotic in the joint or in the bone and then to the body. And that for 10 days, and then you go to the second stage reconstruction. So we do debridement, injection local for 10 days, then replacement by intramedullary nail. And we also published this technique several years ago. You have to remember the anatomy and the biology of the patient with infection. And Sayerny and Mather described this very well. Either the infection is medullary or superficial or diffuse or localized, and the patient can be very good regarding the immunity, local and systemic, or type B, which has a problem with the immunity or the biology. B, local, there's a problem with, for example, the soft tissue or the blood supply, or systemic, like patient with immune compromisation or diabetes or liver problem. Type C is someone the biology is bad and untreatable. So you select the proper treatment for the proper patient, not only according to the extent of infection in the bone anatomically, but also the biology of the patient, the general condition of the patient. Another technique we published is the hemicorticotomy. For example, this patient with chronic osteomyelitis after internal fixation, the patient in the tibia, usually most of these patients had the infection at the anteromedial surface because this surface is subcutaneous with not enough blood supply because most of the muscles are lateral and posterior around the tibia, but the medial anteromedial surface of the tibia is subcutaneous, not covered by bone. This patient had multiple debridement but didn't improve. So we did remove only the anteromedial surface where the infection was, and we did hemicorticotomy. We moved this segment gradually, but we left the lateral cortex intact where the good blood supply is. And so that's how we did it. We did the gradual segment transfer till we reached the docking site, and then we took the external fixator off. So instead of keeping the fixator for a very long time, we needed external fixation for a few months, and then we took it off because we already have a fulcrum and a strut support laterally in this patient. And we published this already in International Orthopedics. Acute shortening, that's also a valid technique, can be used for many patients, like in this patient. So as you see, we have many techniques. You just need to select the proper technique for the proper patient. So please remember, bone infection is a huge problem for everyone. Long time, long duration, depressed patient. Second, you need to think mechanics and biology, not only mechanics and biology, the local biology, the blood supply, and the systemic, which is the immunity. Use the right technique for the right patient. So you need to discuss the options with your patient to select the proper technique and try to think that time is very important. I would prefer taking the patient to the OR 2 or 3 times and cure him or her in a short period of time instead of doing one surgery and keep the patient suffering for 2 years. You need a wise, successful doctor by taking the proper decision for the proper patient, because we need to understand that we are treating a patient, not a piece of bone. At the end, I would like to thank you for listening to my lecture, and I'm waiting the organizing committee to send me any comments or any questions, and I would be happy to answer these questions in the future, and looking forward to see you guys in the international meetings we have, either in the CCOT or the other societies. Thank you very much, and I wish you all the best. Thank you.